Good afternoon. Can we start with the session? Is audio video fine? So beta, let's start with the ENT segment. There were 10 to 11 MCQs. Some were overlapping integrated question with ENT anatomy, ENT with your peds. So we'll be discussing all these important points. Let's start. The first MCQ I have taken from rhinology. They have shown you one lateral view of nasal bone. They have shown you one fracture nasal bone, lateral x-ray of the nasal bone showing a bone fracture, and they have asked you the instrument which we are using for this patient. So you tell me which instrument will be using among the given options. Yes. Yes, very good afternoon all the students. Can you update in the chat box, is audio video fine? Can we start with the session? Is audio video fine? Can you update in the chat box, is audio video fine? So let's start with the first MCQ. A patient with nasal trauma, roadside accident. They have shown you X-ray lateral view of the nose. They have shown you lateral view, and they have asked you which instrument is commonly reduced. Now let's start with this MCQ beta. What we have learned in the classroom. In classroom, the concept we have learned, if I want to reduce the lateral wall, I'll be using Welsham forceps, and if I want to reduce the septal cartilage, I'll be going for which forceps beta? Ash forceps. This is something we have learned in the classroom. What is the important concept of nasal fracture? That is your nasal fracture, facial fracture. The three important concepts which should be on your tips. One, facial fracture. Because edema is there, we have to reduce immediately. All the students listening to me, can you update in the chat box, is audio video fine? Everything? So I'll be trying my best to use this question to teach you all the important concepts related with the fracture beta, what we have learned in the classroom. And this NEET, I will say it was a tricky paper. It was a moderate as far difficulty level is concerned. They have asked you very nice concepts, but in an integrated way. Clear? This was a typical NEET paper, but I will say on this level of MCQs. So what we have learned in the classroom, facial fracture. Always remember, it should be reduced immediately. Everybody should reply in the chat box what we have learned in the classroom immediately. If edema is there, I will go for anti-inflammatory and I will reduce after 5 to 7 days. This is what we have learned. If patient come off within 3 weeks, I'll go for close reduction. And after 3 weeks beta, we have to open because we have to dissect all the fibrous band. So answer should be in this MCQ, answer will be here. Welsham forceps. 4 important concepts I taught. Let's rule out the other options. Ash forceps, it is for septal cartilage. Killian speculum, it is for nasal cavity examination. And septal elevator, these type of options were there. It is for your septoplasty, where we have to raise the mucoperichondrium. Is it clear? So answer will be your option, Welsham forceps. Very important. Lateral view. Nasal bone is the most common fracture. Nasal bone. Can you tell me what is the second most common in the chat box? Which is second most common? Everybody should reply. Now exam is over. What I will suggest you, let's use these recall sessions for upcoming INSCT examination. For the upcoming examination, you tell me what is the second most common? Zygomatic fracture. Always remember zygoma fracture. What are the 2 keywords for zygomatic fracture which I am expecting for your upcoming examination? That is your teardrop sign. Always remember zygomatic fracture, teardrop sign, and one is tripod fracture. It is known as tripod fracture. Is it clear? So answer will be your option C. Coming to the next one, nicely formatted question. Patient 50-year of age with tinnitus, ear fullness, hearing loss on the right ear. He was having some vertigo, headache, progressive loss. Now listen carefully. If I go with the option, if very good beta, Dr. Goswami, it is diaphragmatic fracture, very true. Now, if it is fullness of ear, if I read this question, it is going in the favor of mean ears. Answer should go in the favor of mean ears. Yes. Hearing loss on examination, patient is having vertigo, progressive loss of balance, audiometry, moderate sensory hearing loss, sensory deafness, right here. So moderate is your sensory deafness, again going in the favor of mean ears. But in the last line, they have mentioned Antony A, Antony B cell. So what we have learned in the classroom, beta, otosclerosis, mean ears, and acoustic neuroma. If examiner give me a typical history of pregnant female complaining of hearing loss, which that loss increased during pregnancy. On examination, they give you 2000 loss in bone conduction. Can you tell me what we call it as Carhart notch, 2000 Hz? Or they show you a red tympanic membrane, early stage of otosclerosis, red tympanic membrane, that is known as which sign? Schwartz sign. So in my MCQ, if they mention the word pregnancy, they mention the word Carhart notch, they mention the word 2000 Hz, they mention Schwartz sign, flamingo pink sign, I will go for otosclerosis. In the MCQ, if examiner mention the word recruitment phenomena, what is recruitment? Oversensitivity, because of which patient is very uncomfortable in noisy surrounding, that is your Tullio's phenomena, recruitment phenomena. If these words are there, I'll be going for mean ears disease. Is it clear? Patient is oversensitive to any increase in sound. Recruitment word, Tullio's phenomena, low frequency hearing loss. If examiner give me a rising curve graph, low frequency hearing loss, we go in the favor of mean ears disease. In the MCQ, if examiner mention the word rollover phenomena or decay test, positive tone decay test, threshold decay test, rollover phenomena, examiner use a word ice cone appearance in the MCQ, that is going in the favor of acoustic neuroma. Now listen carefully, beta. Conductive deafness is very easy to diagnose because you are having an airborne cap, so we can make a diagnosis of conductive deafness. But it is very difficult to differentiate sensory from neural. So these are the keyword which help me in the MCQ or in the clinical diagnosis, that is Antony A, Antony B, ice cone appearance, we go for acoustic neuroma. So answer in this MCQ will be your acoustic neuroma, that is vestibular schwannomas. So option A will be the best choice. Is it clear? Crystal clear. Done. Coming to the next one, this is a typical ice cone appearance, but never jump on seeing the word ice cone appearance. Ice cone appearance of middle ear is a normal finding, beta. In middle ear, head of the male ears and long process of incus make a nice ice cone appearance. So just remember, in ice cone appearance of CP angle is abnormal, that is otherwise it is normal finding. Question number 3. Now let's use this opportunity to dissect these questions. Now question number 3 was a very tricky question. Everyone should update in the chat box how many students attempted myringoplasty, how many students attempted MRM in this patient, modified radical mastectomy. In the first go on Sunday evening, when I discussed this question, many students were saying there was perforation shown and the examiner was asking the treatment, hearing loss was there. But over the last 2 days, what I have discussed this question with many students, I am getting one nutshell, what I am sharing on this platform. Examiner have mentioned ear discharge with hearing loss and there was a subtotal perforation. My question to everyone watching this video, can you update in the chat box, was the ear discharge, active discharge was present, was absent? My simple question to you, discharge was there or was it dry ear? Because it will change the answer. Yes, everyone should tell me, Dr. Reddy, you attempted MRM. Okay, then my question is, examiner have mentioned the word ear discharge or it was a dry ear. Tell me, every student. Now, what difference it will make? Hearing loss, conductive deafness, perforation, CSM. Patient is a known case of CSM. So we can have either tubotympanic chronic ear discharge was there. Chronic ear discharge word. Now listen carefully. What is the importance, beta? It can be tubotympanic. It can be atticoantral because it is a subtotal perforation. But the basic logic I taught you in the classroom, disease in the lower part. It is tubotympanic ear, safe ear. Disease in the upper part, atticoantral, unsafe ear. Done. But examiner have mentioned the word total. They have given you a big perforation. Atticotomy cannot be the right answer, beta. Atticotomy is only reserved for Dr. Goswami, beta. Atticotomy when the pathology is confined to mastoid only, then I will go for atticotomy. Now, if ear discharge is there, is absent, let's say no ear discharge, only perforation, central perforation, dry ear, I will go for tympanoplasty. And among the four options, the option for tympanoplasty is type 1 tympanoplasty, that is myringoplasty. I hope you are getting my point. Tympanoplasty. Dekho beta, two options I can directly rule out. Atticotomy cannot be the right answer. Explorative tympanotomy, we go for explorative tympanotomy when the tympanic membrane is intact. I want to make a diagnosis of conductive deafness. Dr. Aditi, I have not mentioned it cannot be MRM. I am just making a flow chart for you. If ear discharge was not there, it was dry ear, we go for tympanoplasty. If ear discharge is there, present in active disease, beta, we never keep the graft. If we keep the graft, it will be a big failure. If ear discharge was there, chronic ear discharge with perforation given, subtotal perforation, and any other finding which is going in the severity of the disease, I will go for unsafe ear, canal wall down procedure, MRM, modified radical mastectomy. Let's dissect now. Everybody is responding in the chat box. That's best part. But what I got the message from most of the student, the patient was having active ear discharge. So I will change my answer from myringoplasty to modified radical mastectomy. Is it clear? Is it clear? Now one student is saying all the ossicles are damage. The ossicle injury may not be there in safe, unsafe. Ossicular damage is not a criteria to differentiate. Chronic ear discharge with perforation, big subtotal perforation, granulation visible, diagnosis going in favor of unsafe ear. My answer will be with MRM, modified radical mastectomy. But honestly, beta, nobody know. I'm not confident about the options. What was the option in the exam, which was a typical history? But for the upcoming Central Institute, for upcoming examination, just remember tympanoplasty will be done if your ear is dry. Is it clear? Done. Modified radical mastectomy, canal wall down procedure, where we are bringing the posterior wall down to reduce the chance of reoccurrence. And what is the drawback? Drawback of canal wall down is your facial nerve palsy. Let's take some important points. The students are ossicular damage नहीं दिख रहा था. ठीक है बेटा. If ossicular damage will not be the deciding factor here. Options are correct. Thanks for that, beta. All these four options, we work hard for all these. This MCQ was covered in the workbook. Absolutely yes. But in the workbook, I have given you this same image. Disease in the lower part, it is here. Safe here. Disease in the upper part, unsafe here. One student, Dr. Harshit, very nice update. The perforation was marginal. If it is a marginal perforation, again going in the favor of severity, unsafe ear, MRM. High probability, answer was MRM in this MCQ. Is it clear? Done. And I hope you remember my words. The students who are confident of making the flow charts always able to attempt the MCQ. The NEET was a game of keywords. If you're confident of the keywords, you can crack the MCQ nicely. Clear? Identify the structure on the AP view. They have shown you some AP view on which they have asked you to attempt the marked area. What is this marked area? If the arrow was on the upper part of this thyroid, it would have been velicular. But if the arrow was on the lower, most of the students were saying arrow was on the lower side. Answer will be here, piriform sinus. Is it clear? Now one Dr. Rakesh is writing in the chat box, case a granulation tissue was visible, but if the no granulation tissue was there, none of the other keywords is there, so nothing is suggesting of atticoantral. But let's keep this question. Either its answer was tympanoplasty, maryngoplasty, or MRM, depending on the complete history of the MCQ. If they have mentioned the word granulation, marginal perforation, but many students are saying it was subtotal perforation touching the margins, it is going more in the favor of MRM. But again, I will say, beta, don't calculate your marks and nothing. It is just a healthy discussion going on. Clear? So answer should be more probability, it should be MRM. Here answer should be piriform fossa. I think there was no ambiguity, no query in this question. They have that. Everyone kindly confirm arrow was at number 1 or number 2. If it was at number 1, it was velicular. If it was at number 2, it should be piriform fossa. Clear? Question number 5. It was direct hit from our question bank workbook. At the end of the workbook, I have given you 100 MCQs. Epistaxis, initial method failed. Chronic diabetic hypertensive, typical history. The same history was there. What is the next step? Transendoscopic ligation of sphenopalatine artery. Clear? So in this, I hope there was no query. Epistaxis mandatory. Even in the DVT, I highlight this point. Okay, last year they have asked you polyps. This year they will ask you epistaxis, either Trotter's method or telespa. What is Trotter's method? Pinch the nose, spit out the blood. Trotter's method. Telespa, transendoscopic ligation of sphenopalatine artery. Artery of epistaxis, that is here sphenopalatine. One student is saying, Dr. Rakesh, posterior ethmoid was there in the option. Even the posterior ethmoid was there. I will go in the favor of sphenopalatine artery. Is it clear? It supplies the major part of your nasal cavity. Answer will be your option 3. Trotter's method, epistaxis. Trotter's tried, beta. Again, flowcharts. If examiner asks you in upcoming examinations, I will request every student, beta, just don't waste your time in calculating the marks and over assessment of the results, branches, ranking. Not at all at this point. At this point, relax your mind for 1 week and then restart for the Central Institute. Is it clear? Trotter's method is for epistaxis. Trotter's triad, that is your 5th and 10th now palsy, nasopharyngeal carcinoma, favorite topic of Central Institute. So answer will be Trotter's method, epistaxis, Trotter's triad, nasopharyngeal carcinoma. Clear? Kisselback plexus, Dr. Rakesh, beta, Kissel, what you are saying, what I am getting from your mail update, your comments, you are saying sphenopalatine artery is only related with your latest. No, ऐसा नहीं है. It even supply the posterior part of nose. So answer can be sphenopalatine artery. Clear? Question number 6. ये तो बेटा गलत नहीं करा. I hope every student have attempted this question right. Angiofibroma, recurrent epistaxis. If you have attended our NEET marathon session 2-3 days before your NEET exam, the first statement I have updated, that video is there on the YouTube, where I have told epistaxis, angiofibroma, and pure tone audiometry. These are 3 mandatory questions for the upcoming NEET exam, and all the 3 were there. That is angiofibroma, vascular tumor. Which are the 10 keywords? Revise with me. Sphenopalatine foramen, young boy. Resistant epistaxis, sphenopalatine foramen, most common site. Dumbbell shaped tumor, posterior wall bending down, Hallman-Miller sign. No biopsy, no debulking. Internal maxillary artery to be embolized to reduce the size of the tumor. Treatment, always remove the tumor in toto. So beta, if you can manage to revise angiofibroma in 1 minute, you are on the other side of this game. Again, I'm repeating, concise notes which we can revise multiple times is the game changer. So work hard on the important ke. The answer was here angiofibroma. Let's crack other options. Enteroconal polyp. I mean, my MCQ, if examiner mentioned the age 10 to 14 years, adolescent, A for enteroconal, A for adolescent, pearly white mass, bleeding not mentioned, I will go for enteroconal polyp. 20 to 40-year-old patient, bilateral grape-like polyps, ethmoidal polyps. Any polyp which reoccur is ethmoidal polyp. Middle-aged patient from southern part, Tamil Nadu, history of taking bath in the ponds, mulberry-like polyp coming out, I will go for rhinosporiosis. Is it clear? So answer in this MCQ will be your angiofibroma. It will be your angiofibroma. Is it clear? Coming to the next one, yeah, question number 7. They have asked you, they have given some audiogram, audiometry finding, airborne gap on the left side. Renes was negative on the left side, positive on the right side. I think this is one of the easiest question. Renes, what we have learned in the classroom, beta. Renes positive, negative, or false negative Renes. 3 type of Renes. Renes positive means air conduction better than bone conduction. AC better than BC. Normal, sensory, and neural. Renes negative means BC better than AC. Is better than AC is conductive deafness. False negative, lack of masking in severe unilateral sensory neural deafness. Is it clear? Weber, 3 important MCQs on Weber. Centralized in normal. In normal human being, Weber is centralized. It is lateralized to better ear. Lateralized to better ear in sensory neural. Lateralized to disease ear. Worse ear in conductive deafness. It was simple. Point clear. Straightforward concepts. Done. Weber was lateralized. Right was, left was ear. C worse than BC. Yes, air conduction more than bone conduction. So it will be, the audiogram may be different. It was ear conductive. I'm just showing you the PTA, pure tone audiogram. They have shown you some audiogram. It was similar to this where they have shown you airborne gap and right side was on normal. Is it clear? So answer will be left conductive deafness. In large orange color tonsil is seen in. So this was a PYQ repeated from your Central Institute. It was Tanger's disease. Is it clear? Yes, beta. Dr. Patel, right side, your right side finding was normal. It was on the normal side. Clear? Then they have given you one MCQ on which is a true statement regarding orbital complication. Orbital complication of sinocitis. Ethmoidal sinocitis is most common. If it is a complicated case, I will not go with the topical antibiotics. It cannot be the treatment of choice. Only anterior, not at all. Ocular movement cannot be normal. So we can rule out the other option. Answer will be your option B. Ethmoidal sinocitis most common. First 4 complication: mucocele, pyocele, osteomyelitis, fistula. These 4 complications seen in frontal sinus. Orbital cellulitis, orbital abscess, they are common in ethmoid sinus. Yes, beta, there was a left side was having the airborne gap and right side there was no airborne gap. Clear? So it was left conductive deafness, left conductive. One MCQ, again one was PYQ. A old patient, difficulty in swallowing. Patient was diagnosed with laryngeal carcinoma. Surgical management was done. They have shown you one slide. The question is, this patient is having CLA carcinoma, surgery either partial or total. So how to differentiate? Permanent tracheostomy. So beta, if there is no tracheostomy, I go in the favor of partial laryngectomy. If tracheostomy done, it was total laryngectomy. So answer should be there. Clear? That is a total. Thanks for all the compliments in the chat box, beta. That's great. All the questions were from the workbook. We have discussed all these questions in the DVT session, in PYQs, and the best part was okay, every concept was there from the class notes only. So it's better just stuck to the class notes which are doable, which are concise and crisp, beta. This NEET have proved that. They will never ask you hi-fi things. They will ask you very simple, straightforward. Clear? This surgical management, you tell me, what will be the treatment? What will be the treatment This will be total laryngectomy. This will be total. It cannot be partial. It cannot be partial. Is it clear? Because they have shown you a opening on the anterior wall. Opening on the anterior wall. Is it clear? Then if I draw a line diagram of a patient after total laryngectomy, your larynx is removed from above, we close. On the anterior wall, always remember, on the anterior wall of trachea, we have tracheostomy tube. On the posterior wall, we put a prosthesis from where the patient will speak out. That is known as tracheoesophageal prosthesis. Clear? So this is again one of the important concept they can ask you. On the anterior wall, tracheostomy tube. On the posterior wall, it is tracheoesophageal prosthesis. Clear? Dr. Patel, I agree with you. Audiogram was not the same. I have just taken one image to recollect that the examiner have shown you some airborne gap on the left side and right side was normal. Renis was negative. Weber was lateralized to left side. So it is again going for conductive deafness only. Is it clear? Done. So answer should be here, total laryngectomy. Total laryngectomy. Clear? So these were the important concepts they have asked you in the exam beta. Best of luck for your results. Again, I will recommend enjoy for few days but restart for upcoming Central Institute. Any query you can inbox in our Telegram group or you can inbox me on the Insta. Thanks a lot for listening to me. We stop at this point.